Hi, good afternoon. I'm going to get us started. We're a small group, but I'm excited for the topic, and I'm grateful for people for being here. I know many of you, but I'll introduce myself. My name is Michael Kaplan. I work as Executive Director at Cascade AIDS Project. It's an exciting time in healthcare, and I know we're all kind of wondering what's happening. And some of us are waiting to hear what the Supreme Court's going to say, and some people think we'll have a decision on Monday, and who knows, but what we do know is that healthcare, regardless of what the Supreme Court does, is happening in Oregon. There are coordinated care organizations coming to be. There is a health exchange already starting, and so there's a lot happening. So despite not knowing what the Supreme Court will say next week, we had hoped we'd hear what they say, but we thought it would still be a timely conversation to talk about health reform and how it's going to impact people living with HIV. Before I introduce the panel, just a few quick housekeeping. I want to thank Benjamin Garrett. He did a lot of work on organizing this, and there's Alayo out there as well. Alayo as well. These two really organized getting people together. I also want to say it's a free program. There is no sponsor, no pharma here. But if you want to be a sponsor, you can text $10, and we gave you that information on your chairs. We're going to just basically, I have three panelists. I'll give an introduction to each before any of them speak. And then I've asked each of them to talk about healthcare reform as they see it from their part of how they touch it. And I'm going to give you a little overview of how they each touch it. And then really the second half hour is to do Q&A and hopefully answer as many questions as we can. We're really lucky in Oregon, not just because you can know the people who are making the change or you can be part of that change, but because we're leading the change in terms of health reform. And I'm excited that I was able to get three people who aren't just experts and kind of knowledgeable about what they're doing, but the long-term allies and advocates and people that we work with at Cascade AIDS Project day to day and who are partners in the work we do. I'm going to do their intros. The first is Tom Burns. And Tom, after working 20 years for California legislature, also worked 18 years for GlaxoSmithKline, tried to retire and failed miserably. 4 days after announcing his retirement, Representative Greenlick asked Tom to help draft HB 2009, which started the Oregon on the plan towards insurance exchange, universal coverage, and reform in the delivery of insurance. After passage of that, Tom was asked by Bruce Goldberg, the head of Oregon Health Authority, to be the director of the new age, to run the pharmacy program for OHA. In his current capacity, he is director of pharmacy programs, which means Care Assist, which is our state ADAP, AIDS Drug Assistance Program, in which many people living with HIV are getting their assistance from, is in his purview at Oregon Health Authority. Tom's going to speak first, but let me tell you the other speakers. Speaking second will be Ed Blackburn, and Ed is a longtime collaborating partner. He's the executive director of Central City Concern. He's worked there for 20 years, but has been the executive director since 2008. Hopefully most of you know CCC, but their mission is providing comprehensive solutions to ending homelessness and have been a critical partner at Cascade AIDS Project and many of our housing programs. They have a staff of 600, an annual budget of $40 million, and serve an estimated 13,000 individuals annually. Besides running a major organization, keeps his foot in health reform in Oregon, and he's doing that in a couple ways. One is he is a member of the executive committee for the Tri-County Medicaid Collaborative, which will be one of, so far, two to be formed coordinated care organizations in the Tri-County area. And based on its membership, probably clearly the largest CCO in the state. And so I've asked him to kind of talk about what that looks like. But he's also chairman of the board for the Oregon Health Co-op, which is consumer-oriented health plans, which is a nonprofit health insurance plan that just got a $58 million grant in March from the feds to start a consumer-driven health plan in Oregon. The third speaker is Liz Baxter. Liz is just a great ally, community advocate. She's the executive director of the We Can Do Better, which is a nonprofit based on the belief that small groups of people can have great impact, and that even a small state like Oregon can influence the national debate on health reform. Liz has a long history in public policy and community. She worked with the Office of Oregon Health Policy and Research, 12 years with Legacy Health System, managing their public and private funded grants in chronic care, primary care, and care management, with an emphasis on connections between medical care and community-based care. She's also done direct community-based work in the 3 Tri-County area. Liz and her partner, which I thought was cool, is a new foster parent myself. We're the first same-gender couple to openly adopt children through Children's Services in Oregon years ago. In fact, all 3 are now adults or on their way to adulthood of her kids. And in 2011, Liz was appointed by Governor Kitzhaber to chair the Oregon Health Insurance Exchange, something she's been grateful for every day since. Or something like that. So I've asked each of them to take 5 to 10 minutes and to talk about what health reform is going to look like in the state of Oregon, whether they think about you as a consumer, whether you're a Medicaid consumer or someone who might buy an individual health plan, what to think about what's going to happen in the next 2 months, what's going to happen in the next 6 months, and what's out there a year, 2, 3 years down the road. And I'm going to ask Tom to go first.
Well, it's a pleasure to be here. So Michael's posed some interesting questions, and I will do what I can. It's oftentimes, when one looks at healthcare, it is so vast and so huge that one oftentimes forgets a little bit of the detail. And unfortunately for the HIV community, at least when it comes in the Medicaid side and the whole CCO things, it sort of got forgotten. I mean, I really hate to say that, but that's the honest truth. Now I'm going to get a lecture from Bruce tomorrow for saying that, but you know, we are now in option 6 on how to move people out of the fee-for-service and the CCOs, and it was only by the time option 6 came along that suddenly said, what are we going to do with all these people who are HIV positive, who are very expensive, and maybe the CCOs won't want them? So I do think it's important that we have these types of conversations, and I will put my little pitch in now. For those of you who are directly impacted by the decisions that are going to be made have been made, and are going to be made starting tomorrow and continuing on every day before this whole thing changes, you need to make sure you're at the table. And if you can't be at the table, there are a lot of advocates who can be. And I strongly encourage you to make sure you're there, because this is so complicated and so hard that it'll be tough to make sure that we don't leave people falling through the cracks. And that's the last thing we want. So let me talk a little bit about, first of all, the conversion to a CCO world. Anybody who is currently in an MCO will move, will move to the corresponding CCO as soon as that CCO goes online. You want definitions? I'm going to say, coordinated care organization. And do we want to define a little better what that is, or are you going to do that, Ed?
Why don't you do it? then I'll figure it out.
Well, I will tell you what it's supposed to be. When we started looking at healthcare reform, we did some in-depth analysis of what was going on in the Medicaid program. And we went to one specific plan that I will not name, a managed care organization, or MCO. And we said, who are your 100 most costly patients? And we looked at those patients and discovered that those patients were using the ER room about 50 times a year. 50. 50. In other words, they were getting their health care through the ER and not through primary care. So then we went a little further and we said, well, okay, why are these people showing up in the ER so often? 70% of them were showing up for a mental illness problem. Well, wait a minute. We have a managed care organization that's supposed to be treating the client. We have managed health care, mental health organizations that were supposed to be treating mental health. Uh-oh, the two of them don't talk to each other, and the two of them are in different hands. And so the people over in the mental health side thought they were treating the patient properly. They were prescribing the drug, they were working with them, but they had no way to know whether the patient was showing up in the ER because they didn't get the drug, because something triggered, whatever, because there was no communication back and forth. How do you fix that? You merge them together. The governor also said, we know that if we could find a way to put air filters in asthmatic homes, that the need for an asthmatic to show up in an ER with an asthma attack would significantly decline. There's no mechanism currently in the Oregon Health Plan to buy an air filter for somebody who's on OHP. We know that people who are diabetic need to make sure that they get their insulin and their test strips and everything else. There was nobody coordinating the care. So you step back, you identify the problems, and you say the solution is to find a way to assign each patient to a particular doctor and have that doctor coordinate their care across mental health, physical health, long-term care, and dental, and try and bring them all together and know that patient and focus on those patients and deliver and treat the patient for the needs of the patient, not simply because the patient showed up in the ER and we're treating him there. So that's a coordinated care organization. Those are set to go live in 10 or so. The or so is that we haven't signed contracts. On August 1st, there is another wave of 5 or 6. Again, we haven't signed contracts that want to go live on September 1st. We're anticipating another wave on October 1st, and the last wave is November 1st. The goal is to have a coordinated care organization that covers the entire state, not one that covers the entire state, but every portion of the state has access to a CCO. Whether we achieve that or not is still up in the air. So back to the people who are HIV positive currently in the OHP program. If you are currently in an MCO, managed care organization, you will automatically move to the corresponding coordinated care. It means that on September 1st, if you're in the Tri-Counties area and you want to be part of the Tri-County CCO, on August 31st, you went to Care Oregon, and that was your health provider, and on September 1st, it's now the Tri-County Consortium. No impact to the patient, we hope. For those who are in fee-for-service, and we know that the Care Assist program just moved about 18 months ago, 350 clients out of OMIP into the fee-for-service OHP, they will continue to get fee-for-service until November 1st, at which point they will be assigned to a CCO. The patient has the right to pick the CCO that covers their area. So if you're in the Multnomah County, there are at this point anticipated 2, the Tri-County Consortium and Family Care. You can pick which one you want to be transitioned to, and there is a team of people, not only the Care Assist folks, but the team people in OHP and in Medicaid who are in the process of putting the plan together and figuring out how to reach out to the clients, educate the clients, and move the clients into a managed care organization. Duals, for anybody who is a dual, that is, you are Medicare eligible, you have a choice. You at this time are not required to move to a CCO. You can stay in fee-for-service if you choose to. We anticipate that I'm going to fast forward a long ways now, in January of 2014, you will be required. And we are in the process of getting waivers from the federal government to require that. We don't know whether we'll get that, but that's our anticipation. Moving out of Medicaid and moving into the OMIP population. OMIP, I don't even know what OMIP stands for. I'm sorry. Oregon Medical Insurance Pool is the high-risk insurance pool in Oregon.
And Tom, can you also clarify why someone would be so the income of sure. Meaning why someone's in Medicaid versus OMIP?
You are in Medicaid if your income is less than 100% of the federal poverty level. If you are not less than 100% of the federal poverty level today and until December 31st of 2013, you have to go find your insurance someplace else. Now, there are exceptions, so I'm sure someone in this room will say, wait a minute, there are exceptions, and there's different categories, but generally, 100% of federal poverty level, you qualify for OHP, and you are treated by Medicaid. Above that, you have to go find your insurance someplace else. The way many people who are HIV positive get their insurance is through OMIP, or the high-risk pool, because that's a state-run program that consolidates all the high-risk patients, puts a levy against all of the private plans that are sold in the state, and uses the levy as well as revenues paid for by the people who are in the program to provide insurance for them, for the clients. In 2014, OMIP at this point will disappear. I'm 99% sure it will disappear, but there's always the 1% that will cause chaos. For the Care Assist clients or anybody else who is HIV positive in OMIP, you will have to go buy your insurance on the open market or through Liz's program, the exchange. And I will let Liz talk more about the exchange. But it is a transition that those of you who are involved in this and those of you who are personally impacted by this, you need to be part of that discussion about how that transition is going to occur. Because if you're not, people will just simply assume that you're going to move and forget about you.
And Tom, for those who are above the 100%, aren't eligible for Medicaid, but do get into OMIP via Care Assist, Ryan White funds, that's up to what? Percentage of income, and what happens to that?
Yeah, 300% of federal poverty level. Yeah. Right. Everybody will move. And the Care Assist, from the Care Assist point of view, again, assuming that we can find a place to buy insurance and that the exchange works as it's supposed to, Care Assist will continue to buy your insurance in the exchange just as you currently do. So you will have more choices because with OMIP, your only choice is to use Regents. If you move to the exchange, there hopefully will be other programs available, and you can buy other insurance in the exchange. But that's Liz's side, and that's her detail, and I don't know all the gory details. There is one little caveat here. Again, currently, Medicaid is 100% of the federal poverty level. On January of 2014, it goes to 133%. So any OMIP client who is between 100 and 133% of the federal poverty level will be moved into Medicaid. You will not be able to buy insurance in the exchange. And so there's another group of people who will be specifically impacted by the upcoming policies, and you need to take responsibility for your health care and get involved. I think at that point I will stop and be happy to answer questions at the end. 2014.
And so I think, and we're going to do wide open to questions at the end, but I'm going to ask us next to have Ed say everything he knows on CCOs, or at least give us a sense.
Well, so I want to try to get this a little bit on the ground here locally. As Tom mentioned, there were 2 CCO applications that were submitted to the state. One was from an MCO known as Family Care, and the other was from a consortium that really started in December in a big way. And that consortium includes Providence Hospital, Kaiser Permanente, Legacy Hospital Systems, OHSU, Quality Care, Adventist, Care Oregon, Clackamas County, Washington County, and Multnomah County, and they're mostly from the mental health side, and then Central City Concern. So we formed a steering committee in December and began working on the relationships, really, because this is a highly complicated thing when you're talking about, certainly not Central City Concern, but these really big institutions that employ thousands of people and have millions of patient visits, in a year, and are very complex organizations. Some of them are regional in terms of their structure, like Providence is a regional organization, so the big boss is in Seattle, and they got a board of directors up there, and Kaiser Permanente, the big boss is in San Francisco, and their board of directors is there, so it's a complicated decision-making structure as well. But this group came together around this idea that providers working with managed care companies could come up with a concept around coordinated care that could be truly different. And it has been a rocking and rolling experience, let me tell you. It's been amazingly fast-paced, and there's been big challenges along the way. We've had a couple in the last week or two that looked like the whole thing might go away, and we solved some problems and keep it together. What's remarkable to me is what people have been willing to put on the table. Because if you look at what the goals of this healthcare transformation, the first is lower cost. And that's based on the knowledge that the current healthcare system is not sustainable. Costs are escalating in the 9 to 12% range every year. Fewer and fewer employers are providing health insurance. I think it's something like 5 million Americans have lost their health insurance through their employer just in the last couple of years. And that might be permanent for a lot of these employers. So something really needs to change. And one of the things that needs to change about lower cost is focusing on payment methodologies that reward big institutions for providing very expensive care, that underpay community-based primary care or mental health services, and keep the infrastructure there way below the capacity needs. And the knowledge, even amongst these CEOs of these big institutions, that's got to change. So they know this is going to cost them some money. And their willingness to stay at the table and help design an approach that actually reduces their payments from the state is a very difficult thing to pull off, even for small nonprofits to agree to do something like that. But for these big institutions, it's very difficult. So some of the big things that need to be accomplished on lower cost is reducing the reliance on emergency departments, hospital beds, psych units, state hospital, mental health institutions, emergency services, and shift the investment patterns differently into primary care, mental health and addictions, but also specialized services for special populations. Those services much more effective at solving problems, upstream. So this is kind of a paradigm shift on where the healthcare dollars need to go, particularly around Medicaid and low-income people who will be eligible for exchange, and federal subsidies at a higher income level. The second thing that needs to be is higher quality. And what is meant by higher quality here is we need a healthcare system that is driven by outcomes and not by how many visits a licensed provider has. This whole business that's made life miserable for a lot of healthcare professionals that, for a primary care doctor, they got to see 24 patients in a day. And if they don't do that on the average, their primary care function is losing money. And that 10-minute visit that is so alienating to most patients and really alienating to the workforce, we got to turn that around and focus on outcomes. And not everything needs to be reliant on seeing a specialist or the higher paid providers. There are providers at a community-based level that can do these services, many of these services at a more cost-effective approaches. So there's a lot of discussion about the role of nurses, nurse practitioners, community health workers, case managers working out in the community to connect people to the services, but also to help teach people how to take care of themselves better, so they don't end up in an emergency department or end up using emergency departments as their primary care or their medical home. So the focus then needs to be on common metrics for determining what good outcomes are, and then designing payment methodologies that reward good outcomes rather than how many visits you generate. The third is with the triple aim is that the patients have a better experience in their health care services. So it really needs a lot of involvement by the members of the CCO over time to be engaged in an active way in which they are helping to push the drift of the CCO development. It's delivery system towards one that's more useful and less alienating and more knowledgeable about what their problems are. So my role as it evolved in the early days in January and February was it was very clear to me that these CEOs of these big institutions, as knowledgeable as they were about their own worlds and their hospital systems, had very little understanding what existed out there in the community in terms of specialized services for special populations, community mental health, addictions treatment, and the case management systems that are out there on a community level. And you know, there's always two phases to change that cause anxiety. The first is, will we be able to get their attention to get something done? Will we ever get there? That's the first phase. Then you get their attention, and then second anxiety is they start doing things that you didn't intend them to do, and start creating all kinds of programs rather than tapping into the community-based agencies and services that are already out there. And that fact did kind of happen in the beginning with a large grant we submitted. So my role was really trying to create space for community-based programs to have access to these decision makers, and I think we've come a long way in understanding understanding of these big decision makers, of what exists out there in the community. And in fact, for this whole thing to be successful, the community-based resources have to be immobilized and engaged, because it is those resources that, if they're funded adequately, if they have enough support, if they can communicate with the big systems and with each other through health information technology, are going to be the most successful at helping us to achieve these three aims of lower cost, better quality, and better patient experience. So this is something that you all need to be paying attention to. I know a lot of you are, but the CCO was founded by 11 members that I just mentioned, and we're in a process now of expanding the board to, I think it's 21 members. So we're expanding it in a number of ways. We've accepted applications and nominations for positions including two physicians in practice, 2 nurses in practice, 1 mental health provider, 1 addictions provider, a community at-large member, and a chair of the Community Advisory Committee, which is also in the process of being set up. And we're receiving applications for the membership of that committee, which must have at least 50% consumers on that committee. So the chair of the Consumer Advisory Committee will be automatically placed on the board of this Tri-County Coordinated Care Organization. So that's all in process now. There is, I think, a commitment by the CCO to continue other types of community outreach. And there's been a lot going on with meetings around the Tri-County area about what we're trying to achieve here. I think on day one, and I think day one, and there's maybe some disagreement about this, is going to be September 2nd, not August 1st for this big thing. I mean, there are CCOs around the state. 11 applications have been submitted. Most of them are, well, all of them are much smaller than what we're trying to do with this collaboration. But on August 2nd, there will be membership of the CCO, just as you may be a member of Care Oregon or some other managed care company. But all of those entities for which you are getting services through now, whether it be Care Oregon or Family Care or through one of the county systems or through Quality Care or Providence, all of those will be in place. Nothing will change on September 2nd. And the reason for that is we could create absolute chaos by trying to create a whole new administrative structure, try to have all the provider contracts that these organizations have, try to do a claims system, and any kind of accounting system that works within this time period would be very likely that a lot of patients would not get the care they needed and a lot of providers wouldn't get paid. So this has got to be a phased-in thing. So the plan, as far as I know, is within 12 to 18 months, indeed, all those managed care companies will be consolidated under the CCO. There will not be 9 different ones in the Tri-County area, but it's going to have to be phased in and phased in carefully to make sure people's care is not being interrupted. So with that,
That's
my
perfect.
time up?
I have
Okay.
a question for you
Okay.
later, but I'm going to let ask Liz. So again, if today, if you're at 100% of poverty or less, you're probably on Medicaid, and you're getting your health care through Oregon Health Plan, and you're getting it through Family Care or Care Oregon. Starting either August 2nd or September 2nd, you will move to one of two CCOs in the Tri-County area, which will be either Family Care or the Tri-County Collaborative, and hopefully when you move, you won't have noticed, except that there's something different on your materials. But if you're over 100% of poverty and below 300 or whatever it is in terms of care assist, you're for a while you'll be fee for service, but eventually the idea is you're going to go into the health exchange, and there's a lot of questions about the health exchange and what the Supreme Court ruling. The Supreme Court rulings, my sense, is going to impact that more than anything. But Liz is chair of the health exchange. I would try to explain kind of where it is, where it's going, perceptions.
Thank you. I hope I can do that. I'm just curious if you feel like you've got room to be confused just a little bit more by terminology, or if you've already maxed out, because I'm going to torque you just a tiny bit more. I want to just ask a quick question to start, and it is, how many of you understand how insurance works? Okay, so I should make you answer then. So I'm going to give you my version of how insurance works, and it is basically you're pooling risk. So you need to have a lot of people who pay something with the expectation that not everybody needs a pay back out. It's, that's just kind of the basics of how insurance has grown and evolved in this country. And for me, so I'm going to give you both with my exchange board hat on and then a tiny bit with it off. So when the Supreme Court announces its decision, because if you've read the papers, the Supreme Court has made its decision. They could have told us already, but they're kind of toying with us. The question really isn't like, what's the Supreme Court going to decide that's going to either totally dismantle what we've been doing and how's it going to affect that? The question that I keep waiting for, so what were we after? And if we either win or lose at the Supreme Court, what do we get? Because at the end of the day, we're not after the same kind of dysfunctional system that we have today, with people being left out the way that they are today, some people buying and not actually getting to use their insurance coverage if they have it. We want something better. And so that 2014, January 1st date was going to be the beginning of something better, while the CCOs were doing all of this work on the ground to start making things better way sooner. And January 1st of 2014 kind of, to me, has two visions. One is, it feels like forever. If you are the folks who are, you don't have insurance, you either are struggling to buy something today, you're trying to get healthcare access and you can't, 2014, I'm sorry, feels like a lifetime from now. For the folks who are inside and doing all of this work that is happening at light speed, January 1st, 2014 feels like it's like tomorrow. And there's so much that has to happen. And I think that where you play a role, and I think that both Tom and Ed said this, your job to keep reminding policymakers and decision makers, there's a big crevasse between here and January 1st of 2014, and there are things that need to be paid attention to, whether they're impacting the decisions that are being made. They need to hear from you. And I can tell you, in so many ways, regardless of the story that you carry, we need to be hearing from you. Because I kid you not, I hear from every insurance carrier and health plan way more since I was appointed to the Health Insurance Exchange Board than they cared about emailing me before then. I don't know what changed, seriously. I'm kind of just curious. So in Oregon, so the Affordable Care Act at the federal level, health insurance exchanges were part of the federal legislation that Congress passed. States had the option. They could either build their own insurance exchange, or somehow, at some moment in time when states said, we're not going to build one, in a hurry, the federal government was going to build one, and we would all use the federal government's version of a health insurance exchange. In Oregon, there was legislation passed in 2011 that said we're going to do our own insurance exchange. But in reality, the discussion and conversation about Oregon and an insurance exchange started probably in 2005. It has been just kind of this thing that has been studied. Could we do this? Could we actually change the way that Oregonians have access to insurance? Policymakers have been talking about this easily since 2005 and maybe before then. And so what the bill in 2011 did is it created the Health Insurance Exchange Corporation. And this is part of my confusing thing because it's kind of like those words that become verbs and nouns, and you go, can you stop just for a minute? So the exchange is the name of the corporation that's been created. But very commonly, the exchange is also the word that's used to describe that place that you're going to go on your website and buy insurance. So I want to distinguish between the corporation and the place that you're going to go to because they are two very different things. And because things are moving at light speed, the exchange corporation may have a new name in 2 months, and that will help me immensely, more than you can imagine. It's a public corporation. So the insurance exchange, not state government. It is a public corporation that has a board of directors. We have fiduciary responsibility for this thing, the health insurance exchange. And because of that, and the way that the legislation was written, this public corporation, everything that we do, open to the public. So when our board of directors meets, it's an open public meeting that anyone can come and sign up and say, hey, I want to speak to this board of directors. I want to influence what it is that you've got on your discussion today. As well as the legislation created a consumer advisory committee. And it is made up of people who are both individuals, people who are part of small employers, so less than 50 employees, and advocates who might be representing people who, in January of 2014, might be purchasing insurance through the insurance exchange. So we're doing both a future tense and a past tense when we talk about the exchange. We've created this community advisory committee, also open to the public. They take public input. You can talk to anybody who's on this community advisory committee. The website, which, anybody read Harry Potter? Anybody Harry Potter? So, sorry, this is where Rocky gets upset with me. So the temporary name and the website is ORHIX, Orhix. And when they told me that they were going to name it Orhix temporarily, I said, oh, that's like Harry Potter and the Horcruxes. It's not a name that kind of flies off of your lips very easily. But you can go to orhix.org. You can sign up to learn about the exchange, get email updates. They will send you an email every time the Consumer Advisory Committee meets. When the board is meeting, anything that's new that they are looking for public input on, you would get an email to your email box. And I'm going to say, please respond. Because the decisions that are sitting within the exchange today, so not in 2014, but today, what exactly is going to be the benchmark plan by which we measure all other plans that get offered in the insurance exchange? There's this group that actually Michael is a part of, the Essential Health Benefits Work Group, that has been charged by the governor with deciding what's our floor. What's the floor that we're going to set in Oregon? And it's going to be open for public comment for a very kind of a 3 or 4 week window. Please look at what they're recommending and give some input on this. It is going to determine kind of what's that, is it the bronze level? They refer to it as the metals. And I always think of it as the metals, which is terrible, but it's the metals. So there's going to be a bronze plans, silver plans, gold plans, platinum plans. The decision that's being made this summer, what are those bronze plans going to look like? What are they going to cost if somebody is purchasing in the exchange? There's some requirements about what benefit categories have to be in there, but there's a lot that's going to be up to this work group to really make some recommendations on. And in August, the Exchange Board and the Health Policy Board are going to jointly meet, make a recommendation to the governor, but it's the governor who's going to say, here's the benchmark for Oregon and how we move forward. And part of the reason this benchmark work is so important, it's about inside and outside of the exchange. So even if you're somebody who might not purchase through the insurance exchange and you want to just go to, Blue Cross and buy something, this benchmark is going to be the benchmark for Oregon statewide. So it's incredibly important. The mission of the exchange, and Ed mentioned this thing, the triple aim. And so when the exchange was being created, the board had the ability to kind of refine the mission. And rather than going, let's just be in another silo and let's create this web portal that will be the place that people go and purchase insurance, we said, you know what, we actually want to be connected. We want to be connected to the work that's happening around changing Medicaid. We want to be connected to things like, creating medical homes. We want to make sure that this exchange becomes part of the health reform that's happening across the state. And so I want to read the mission to you because there are 4 pieces to it, and each one of these 4 pieces to me are incredibly important. It starts by saying, and there are folks who refer to the exchange as like Travelocity. It's going to be like this website, this web portal. I actually drew this thing on my notes here that says, no, we are not Travelocity. So the mission of the exchange, to improve the health of Oregonians, not to get everybody to purchase insurance, but to improve the health of Oregonians by providing health coverage options, increasing access to information, and fostering quality and value in the healthcare system. Our board spent probably 2 8-hour meetings deciding that was our mission. It was not a mission to create a web portal that would look like Travelocity. And part of the reason why, if I'm in my car and I hear, Christian Foden-Wenzel, hope he's not here, say, this is just like Travelocity, I say, only if Travelocity cares about the safety of the airplanes. Do you actually have the ability to get on a plane if you wanted to? What's the criteria? What should the legroom be like? And what is your experience going to be once you get on that plane? Oh yeah, plus we want to lower the cost. Travelocity, I understand that folks who are very much into IT, why they use that as an example, because it's something that people understand. The exchange has to be much more than that, or we are not going to be successful in 2014.
In a minute.
You're going to
give them 15 minutes to ask Q&A.
Okay. So the last thing I'll mention then, because it's the next important thing that the exchange is working on, is that we have to determine what the criteria are going to be to make a health plan qualify to be offered inside the exchange. And again, what would make something be quality. The health plans will tell us what the criteria are that they want to be able to meet in order to offer in the exchange. We need to hear from you as well. It's just critically important that the criteria are criteria that are going to make sure that what you have access to, something that's of quality, that's at a cost you can afford, that is actually going to make your experience accessing the care that you need be better than it is today. Those are just incredible criteria for me. So I will pause there.
Thank you.
Yeah.
So here's the scoop. We have an hour for something that people spend most of their days for the past year working on and still don't understand. But this is to touch the topic, to start thinking about it, to start asking questions. And Tom, and I'll ask panelists to repeat questions so that it gets recorded.
I just want to know
Yes. It's orhix.org. That would be the website that would take you to the health insurance exchange information. Yeah.
Questions, yeah.
Yeah, you keep mentioning that we need to go out there and hear from you. So who is the they? Is it the board, that's board of directors that are together that are putting all of this stuff together?
So you want me to repeat that question, or is that okay because he had the microphone? Okay. So the question was, who is the they that needs to hear from the you? Would that be it? So I think that it is a number of places. I believe that the board does need to hear. I think the board needs to hear what the public is thinking. I think the Community Advisory Committee needs to hear that they actually are representing what the public is thinking. I think that your access to the lead staff who are working on this on a day-to-day basis, they need to hear what you're thinking, because they have set up different teams to get input. They are hearing from the insurance carriers. They're hearing from small employers. They are hearing from labor. They're hearing from groups that are organized in a way that they can actually go to meetings, whether it's in Salem or Portland for an hour in the middle of the week, in the middle of the day. That's harder for most of us. And so however you can do that, when you go to the website, there's a link where you can just give your public input online. There's actually an email address where you can email that, and everything that gets sent to the website, the board members all get a copy of that as well.
I'm going to give an added comment to that as well, and then Tom, which is one of the great things about Oregon is it's small enough to have access to people directly. As Liz mentioned, I'm on the Essential Health Benefits Working Group, and frankly, their call for public comment was worthless. If you read the call for public comment, you wouldn't know how to comment because it didn't have all the information you need to know. And so call people who are on the work group or call people who are on the board and ask them to go to meetings, because I can tell you I've been asked to go to meetings with people who work for big industry so that I can hear their perception. And that's another way to give the input. Tom?
So that's the exchange. There's also the Health Policy Board, which is governing the CCO and the OHP processes. There's also each CCO has a community advisory committee associated with them that have to have a certain percentage of customers as well as community activists that are going to be part of the decision tree for the individual CCOs. So those are two additional places to go.
I want to ask a hypothetical question. Those who are on Medicare, not Medicaid, have a secondary insurance that pretty much covers, with very little copay, their medications. What can they, if any, what change can they expect, if any?
So from the CCO world, very little. If you are below 100% of the poverty level, you will continue to be able to get both a Medicaid and a Medicare benefit through at least January 1st of 2014. We're in the process of seeking a waiver to require you to be part of a CCO, but that has not been resolved yet. That's the exchange.
So I'm going to add something to what Tom said. Here's my hope, that people who are on Medicare with a supplement, you're still going to see improvement because the delivery system is going to change. And I think whether you're purchasing insurance through the exchange or you're getting it elsewhere, that's why it's so important to understand that we're working on multiple things at the same time. That I would hope that regardless of your coverage, you're going to find that your provider is going, well, maybe we should do and I'll get the language wrong, the person-centered primary care medical home. And they might go, you know what, we're going to take all of our patients and do that with them, not just the people on Medicaid. That if these changes make sense and start to make their practices work better, where they feel like they're actually getting better outcomes, I would love to think that they're going to expand that to their whole patient population and not just go, we're going to stay dysfunctional for everybody, but really functional for people on Medicaid. Because if it works, they're going to do it, and they're going to try and expand it. So I would hope that you're going to see changes regardless of where your coverage is coming from.
No matter what the Supreme Court does.
So I think that here's where Oregon probably is, and we'll probably get three versions of this, but regardless of what the Supreme Court does, Oregon's in a unique place because it has passed legislation at the state level. So we're actually operating both at federal and our own state legislature authority. And it takes me back to my first question, which is, if Oregon is as clear as it says it is about this triple aim, lowering costs, getting health out of our health care, and improving the person's experience as they maneuver through the system, regardless of what the Supreme Court decides, that's still driving the reforms and all of the changes that we're doing here. Where money comes and goes, that's going to be a discussion that is above my pay grade. So, but I think that these changes are coming not because Congress passed a law. These changes have been coming because this is really what makes sense in Oregon, and if we did nothing, our system would still be falling apart.
And from the CCO Medicaid side, we're going down that track. And the Supreme Court change will have nothing to do with that. So the CCOs will come.
Sorry, let me go back here and then to you, Tom, just in terms of spreading it out. Yeah.
So I'm relatively new to learning about insurance, but I do understand that with OMIP, you don't need to have proof of citizenship. Am I right? Or is that incorrect? So what happens at the beginning of 2014 with them?
Thank you. I should have mentioned that. A big hole. It's a very serious problem. Liz, I'm going to say it, and you can correct me if I'm not right. In order to buy insurance within the exchange, you must be a legal resident of the country. If you are not, you have to buy insurance outside the exchange. And the issue of what to do with OMIP is that that portion of the OMIP population is a problem, and no one's quite sure how to fix it. If we pull as many lives out of OMIP and put them in the exchange, that means the high-risk pool is very small. That means the cost will go up significantly. Probably not something that you can afford if you are not here legally and not in part of the economic infrastructure. Will there be state dollars? That's a legislative decision that will have to be made. Can the legislature, the Oregon legislature, change the rules on the exchange? No.
So I'm going to take off my exchange hat just for a sec, okay, and add two pieces. One is, again, when I think of who comes to talk about what these rules should be, people who lack documentation, not the first people that are lining up to give testimony in front of, boards and commissions and committees. And so whoever speaks on their behalf needs to keep raising that issue. The second piece, which has been kind of at least put on the table, the restriction about the exchange or anything else and the documentation has to do with the use of federal funds. So the exchange, 100% funded by federal funds, and then in 2015 we have to be self-sustaining. And so one question that's been put forth is, well, could the exchange find other funds, not federal funds, and somehow put a firewall around that work that would allow the simplification and how you get information to have some of that be accessible. But know that one of the things that was in the legislation that created the exchange that I think is an interesting conundrum, the essential health benefit applies inside and outside of the exchange. If a health plan is offered inside and outside of the exchange, it has to be offered at the exact same premium price. So in some ways, there's going to be some impact outside of the exchange because of the way that the legislation was written. But it creates one more fracture. And I think that at the end of the day, what we'd like is to eliminate as many of these fractures as we can.
And as early as we can.
And as
so
early
it
as
doesn't
we can.
happen. We don't run into the problem on January 14.
Tom, did you still?
Yeah. It isn't the first time I've heard outcomes spoken of for payment for mental health services. So with that background, Mike, taking the three goals, which are essentially better care for more people at less cost, have you been discussing how a payment mechanism or beginning to connect that to outcome, which is a very intangible thing in some cases?
What's going on at the Tri-County Coordinated Care Organization is and this is true with all of the CCOs, is that they are now in the process of filing what's called a financial application to the state. So we've gotten provisional acceptance of our contract proposal. Then we're into the situation now we've got to propose a budget to the state and then finalize a contract. So we're in the stage now of submitting the financial model we intend to use. The CCOs at that point, once the contract is concluded, will receive what's called a global budget. Instead of a budget that covers specific diagnoses and specific types of services, I'm sure there'll still be some of that in there, but it's going to be broader. And the coordinated care organization has a lot more freedom on how to spend that money, again, not tied necessarily to a visit with a licensed provider, on a medication management thing or something like that. It could be for social service providers that are helping people stay in their homes, finding out what they need, breaking down the isolation, making sure they're taking their medications, they understand their medications, can keep a lot of people out of EDs, emergency departments. So that's the global budget, and I think over time the idea is that providers in the community who are also getting paid mostly on a patient visit by a qualified provider will also start getting capitated or global contracts, and they'll have flexibility to provide the types of services that they've not been able to do because they couldn't get paid for them, that they know will keep people out of care, and it may not be seeing a physician. It may be seeing another community health worker that can help them shop for food, teach them how to cook, a nurse that can answer questions about a perceived crisis that's not really a crisis, these types of things. So the metrics, and then how do we measure whether all those things are being successful? I think there's going to be some crude metrics in the beginning, and that is what does emergency department utilization look like after we've changed the intervention? Or the delivery system? What has hospital admissions look like for the Medicaid population? And over time, I'm hopeful they can get more and more sophisticated. At Central City Concern, we're looking at what we call a self-sufficiency measure, and it's across many domains. It's not just about income, but it's about housing stability, it's about mental health stability, it's about if a person's in recovery, how are they maintaining their addictions recovery. But it's also about things like socialization and employment readiness and things like this. And so we're trying to come up with a self-sufficiency model, and I think we're pretty close to being there, where we can actually measure people's progress through time. And I think we're trying to figure out something like that for people's health care. Can we really measure a person getting well over time and know that we're doing the right kind of services to get there? But in the beginning, I think it's going to really focus on this issue of cost reduction, because this current spending escalation is not sustainable. And an essential idea of this is that we're going to reduce those costs. It's really reducing the escalation, the rate of escalation. But the goal here in Oregon is reducing that escalation by 2% a year. And the reason the governor was able to get the federal administration to agree to reinvest almost $2 billion back into our system was because he could demonstrate with our system we're going to save the federal government about $11 billion over a 10-year period. And that's a bending of the cost curve. It's not absolute reduction. It's bending of that projected escalation. That's a disaster if we don't do something about it.
I made a promise to Liz, because I know she's excited to get to her next panel at 7 to talk about the health exchange, that we would be done with Q&A at 6:30. But let me wrap with a couple quick things. One is we just wanted to put together a symposium that was an opportunity to talk about topics that are of interest. There are evaluations on your chair. That feedback is helpful to us at Cascade AIDS Project to think about, are there other topics? How did this work? Is this something we should do again? There are, I think, still some light bites out there, and I hope that you'll take advantage of the opportunity to network. And more than anything, I hope you'll join me in thanking the 3 panelists and talking about what's happening. Thank you.